Very good morning, all of you. At the outset, I would like to thank Dr. Rashmin for inviting me to give this talk on OCT in neuro-ophthalmology. So OCT basically captures the tip of the afferent pathway, that is the optic nerve head, and gives us reproducible and quantifiable measurements in terms of the peripapillary retinal nerve fiber layer and the ganglion cell layer. Of late, the enhanced depth imaging gives us the cross-sectional image of the optic nerve head, and it reaches right up to the lamina cribrosa. And it competes with the histological evaluation to study the pathology of optic nerve diseases. With the advent of newer technology, a lot of machines have been added, and with every advancement, a new feature is added. I'm not going into the details of the machines, but I would like to discuss the protocols which are used to capture the peripapillary retinal nerve fiber layer thickness and the ganglion cell layer thickness. So for the RNFL, peripapillary retinal nerve fiber layer thickness, we need a circular cross-sectional retinal scan of around 3.4 to 3.5 millimeter diameter centered around the optic nerve head. Now, the two commonly used SD-OCT machines are the Spectralis and Cirrus. My talk will be mostly around these two protocols. In Spectralis, we get the average RNFL thickness in 4 quadrants like this. And in Cirrus, again, 4 quadrant averages are given. Along with that, 12 clock hour averages are given. In Cirrus machine, these calculations are done based on 6 millimeter into 6 millimeter data cube, which captures, which is done by using the optic disc cube 200 into 200 scan, and this is the output. Coming to the ganglion cell layer in inner plexiform layer thickness analysis, this can be done by a machine which has this feature, that is retinal layer segmentation. So in Spectralis, what we can get is, we can get the ganglion cell and inner plexiform layer thickness separately, whereas in case of Cirrus, it's given as a combined value. And in case of Cirrus, this calculation is done around, it's an ellipse that captures the averages here. In case of Spectralis, it's a circle around 2 millimeter in radius. Now, how do we read these? Now I'm going to show you the Cirrus RNFL map. Here the first thing is that RNFL thickness map is showing the yellow and orange areas are showing where it is thick, and the blue area is showing where it is thin, the retinal nerve fiber layer. And on the right side you can see is the RNFL deviation. That means this thickness, how different is it from the normative data. Then the actual parameters of the optic nerve in terms of the disc area, rim area are also given. You also have the cross-sectional images. You will see all these things, and this is a RNFL circular tomogram. So this is the cut section of retina along this circle here you can see. Next, we also have the NRR thickness from both the eyes and RNFL thickness from both the eyes. And lastly, we get the averages along the clock hours and the 4 quadrants. This is about your RNFL map. Let's look at the GCC map. Again, the same color coding. We are seeing this ellipse. It is showing, the yellow is showing the maximum thickness of the GCC, and the blue is showing the thin area. Adjacent to that is the normative. Compare it with the normative. This is looking pretty normal. The more red and yellow is here, that means it is more abnormal. And then we have the averages along the 6 sectors of the ganglion cell. Now, how is it important? These two things, the play of these two things, we'll see in the clinical use of OCT in neuro-ophthalmology, our today's topic. So, in optic neuritis, what we see is there is thinning of the RNFL, peripapillary RNFL. What is important is that it is not attack-based. That is, even if the patient has not had optic neuritis, has multiple sclerosis, then just like patients with Alzheimer's and Parkinson's, they show a progressive thinning of the RNFL. The same thing happens in multiple sclerosis. Whereas if a patient has NMO spectrum disorder, the patient gets an attack of optic neuritis and there is a thinning. So that's the main thing. In acute case, obviously there is exoplasmic flow stasis, then you will have thickening. And this thickening gradually over 4 weeks sets into thinning, and one peculiarity in NMO spectrum disorder is that the superior and inferior quadrants are more often involved, and in case of MS optic neuritis, the temporal quadrant thinning is more often seen. But retinal nerve fiber layer thinning is not, you can't correlate it with the visual acuity or the fields of the patient. Whereas the ganglion cell thinning, ganglion cell layer thinning correlates very well with the vision and also with the visual fields of the patient. In NMO, again, this layer is severely thinned out. You see a lot of red there in NMO spectrum disorder, optic neuritis. Takes around 2 weeks. We saw that thickening of the RNFL is immediate. This takes 2 weeks. Now let's look at some examples. This is MS optic neuritis, acute attack in the right eye. And here you can see acute attack. There is some thickening of the RNFL here. And what we see is in the left eye also, there is some thinning occurring there. So it's showing that in the left eye also something has happened. So OCT can detect subclinical disease activity, and it is showing me that there is dissemination of disease in time and space. The other eye is involved time because it's like you've captured between that in the past you have captured the attack has occurred. Similarly, if the OCT is showing same values over a period of time, then and the patient is on treatment for MS, then it can be taken as evidence of disease, no disease activity, NIDA. Okay. Now in NMO spectrum disorder, here the disease is very aggressive. Patient had such a poor vision, right eye, it could not be done. Left eye, you can see that superior and inferior, there is thinning. As I said before, it is more often seen. Now, what do we glean from the GCC layer? The same two patients, multiple sclerosis, right eye. I said nothing will happen within 2 weeks, so there is nothing happening in the GCC averages in the right eye. But in the left eye, where there was only one quadrant involved in the RNFL, here you can see lot of thinning occurring in the GCC. And in NMO spectrum, it's all around red. Severe thinning is seen. Another feature is microcystic macular changes. When the optic neuritis is very severe, that is 20% of cases with NMO spectrum disorder and 1 to 5% cases of MS optic neuritis, you see small hyporeflective spaces in the inner nuclear layer, and it occurs because of the loss of the retinal Muller cell function. Now, can we use RNFL thickness to diagnose a patient with cellular mass? Let's see. Now, this patient has a cellular mass, and I'm seeing that in the right eye, the RNFL thickness is normal. In the left eye, there is a few clock hours of thinning. But look at the visual fields. It's giving me much more information. I'd rather use visual fields to diagnose, okay? That's what the papers say. But now let's see what the GCC layer tells. The same patient. Now look at the GCC. GCC is telling me more than fields if you see here. It's completely washed off here in the left eye, and here fields is still showing some area, white area. And the hemianopic defect is perfectly matching with the hemianopic defect in the visual field. So hemianopia on perimetry can present as hemimacular atrophy on the GCC thickness map. This is important, and it occurs before the visual field changes. Okay, I showed you here it's occurring before the visual field changes. Another thing that it can be used is for monitoring the patients. So you've done the surgery and you want to monitor. If this patient, I've done OCT in 2016 and in 2019, it's remaining the same. I know there's no chiasmal compression, at least that much I can tell. Another thing it can be used for is in predicting the visual outcome. If there is severe RNFL thinning, severe GCC thinning, then you can tell the patient that not going to recover much after the surgery. In ischemic optic neuropathy, you can diagnose a cupless disc in objective way. You can pick up the subfoveal fluid and you can tell, while you'll regain vision when this fluid gets absorbed. In acute cases of NAION, you have a disc swelling, and then over a period of 2 months, 80% of patients subsequently show RNFL thinning. Now coming to OCT in pseudopapilledema, this is like in continuous evaluation. Now in pseudopapilledema, around 60% of patients will have these peripapillary hyperreflective ovoid mass-like structures which are called forms. And these are actually herniating optic nerve fibers. And you can see in acute, this is true papilledema here, and this is forms. Inferiorly, you can see this is pseudopapilledema. But these forms can be present in other conditions also. Now, in pseudopapilledema, certain pseudopapilledemas are associated with drusen. Not every pseudopapilledema is drusen, but there are certain pseudopapilledema with drusen, which the Optic Disc Drusen Studies Consortium has defined as hyporeflective core with crenated hyperreflective margins.
Shikha, one more minute.
Yeah. So I'll stop when you ask me to. So SD OCT should be done in EDI mode, 97 sections, and autofluorescence should also be used. These are some more images from there. In true papilledema, you can pre and post treatment monitor, but GCC should be maintained if you want to prove that the treatment. If you're losing GCC, that means there is the treatment is not working. The last two slides, very important to differentiate optic neuropathy from maculopathy. This is where it really is in use clinically in Azure and HCQ toxicity. And new thing that is swept source OCT can be used to diagnose the congenital disc anomaly. Here you can see the disc pit with the disc pit maculopathy. And this is my last slide. OCT, I'm not going into it, but one important thing is that this layer PRC and peripapillary radial capillary network is not visible on FFA, but is visible on OCT. Thank you.
Thank you, Shikha. Any comments from the chairpersons, and then I'll invite panel maybe for.
I think Dr. Shikha has very nicely given an overview of how the OCT has enhanced the corroboration of the findings which were otherwise known, giving the diagnostic aspect, especially in conditions like papilledema, distinguishing from pseudopapilledema, which has become a very good asset in our armamentarium. And we have also seen, in addition, that the angle which is made by the pigment epithelial layer, which is different in glaucoma. In glaucoma, it is moved towards the backwards, whereas in the papilledemas we have found, compared to the pseudopapilledema, the angle made is in line. So this, I think, is there in the IG also published. So this is another additional thing. If you take a cube of the optic nerve head, just like the macular cube, you can use the same program for the optic nerve head. You can have the angulation of the pigment epithelial layer, which will tell us a differentiation from a papilledema from pseudopapilledema. And the drusen, of course, she has nicely highlighted the role of foams.
Any comment or question from the panel?
Just have one point to make. Apart from diagnosing or monitoring nerve fiber layer in tumors being operated, can we monitor the course of papilledema? Apart from diagnosing it, can we also monitor the course of papilledema who are on treatment? So,
Provided we have the GCC layer thickness maintained, you can monitor RNA cell thickness going down after treatment is a good sign, but you also have to look at the GCC. If GCC is also going down, that means RNA cell thickness is going down because of atrophy, not because of treatment. So that's the only catch.
Yeah, and the angle also tells us, by the way. If you measure the angle, that will also show us in prognosticating, because after the papilledema is controlled, this angle gets normalized. So that's another tool.
Dr. SHIKHA, that GCL and IPL is much more for this toxic optic neuropathy. They can give so much evidence. Now, do you find Alzheimer or Parkinson effect in GCL and IPL if you have screened those patients? Because that is where
Marker.